So this diarrhea, as you know, so it is defined by WHO as 3 or more loose or watery stools in a 24-hour period. So this can range from acute self-limiting episode to severe chronic illness. And what is the pathology? There will be a passage of excess of water in feces. So what are the changes that is happening in diarrhea? There will be decreased electrolyte and water absorption, increased secretion by the intestinal mucosa, increased luminal osmotic load, and inflammation of mucosa and exudation into lumen. So these are all self-explanatory, no need to discuss. Then what are the principles of management? So we have to find out the cause, isn't it? Underlying cause, and then you have to institute the specific therapy. And majority of the enteropathogens, it will be removed by the motility, that is by the diarrhea itself. Most of the these toxic pathogens will be removed. Then what are the therapeutic measures? Yes, there will be dehydration. So we have to give correct the fluid depletion, shock, acidosis. Then we have to give the good nutrition, then drug therapy. Drug therapy will come only the last. So rehydration, there is dehydration in diarrhea, so we have to rehydrate either by orally or intravenous. So for every diarrhea or loose motion, we won't give intravenous fluid, but when there is more than 10% of body weight fluid loss, then only we will go for intravenous rehydration. Or if he is unable to take oral fluids due to weakness or stupor or vomiting, then we will give intravenous fluid. So the important, the recommended fluid name is DACA fluid. Another fluid also we can use, but that is the recommended fluid. Then, how it should be given? It is volume equivalent to 10% of the body weight. It should be infused over 2 to 4 hours. So 10% of the body weight. If suppose if it is 50 kg, so 10% of that it will be 5. So that much it should be 5 liters. It should be within. If there is dehydration more than 10% of the body weight, it should be done. Then we can change over to oral rehydration also. Oral rehydration, it comes only when there is mild fluid loss, that is 5 to 7% loss, or moderate 7.5 to 10%. So after 10 only we are going for intravenous. Then what are the principles governing the composition of oral rehydration salt? You have seen this, you might have seen the ORS packets. So what are the governing composition? That it should be isotonic. Isotonic, that is plasma, the osmolarity will be around 290. So it should be between 200 to 310 milliosmol per liter. That is number one. Number two, the glucose, molar ratio of glucose should be equal to or somewhat higher than sodium, because this glucose, it helps in the absorption of reabsorption of sodium. Then potassium as well as bicarbonate, it should be in 15 to 25 and 8 to 12. So this is the principle governing the composition. Then previously there was a ORS, but now WHO has found out another low sodium, low glucose ORS. So what are the advantages of this low sodium and low glucose ORS? Because the stool volume will be reduced by even by 20%. Then incidence of vomiting, it is reduced by 30% compared to older one. Then permits faster water absorption. Then risk of hypernatremia. That means if there is high sodium, there will be hypernatremia. That is not there, and it is cheaper also. So that is in 2002, WHO has found out a new ORS packet, ORS, and it is safe in cholera also. So this is the packet. You would have seen the electrol, oral rehydration salt. So this is the low osmolarity WHO, the new ORS. So previously it was 310. Now this one is only 245 milliosmol per liter. It is low sodium and low glucose. Okay. So this is the the latest osmolarity you have to remember it is 245 milliosmol per liter. Older one was 310. Okay. Now, how it should be administered? The patient should be encouraged to drink ORS at half to 1 hourly interval. And see, some thirst will be the adequate driving force. So when there is dehydration, we will be having thirst. So thirst is an indication that we have to take fluid. So you can take like that. And sometimes the child, if it happens in children, he may not be, he will be refusing to drink. Such cases, we can give intragastric. See, this like this into the stomach directly, intragastric drip. We can start. Okay. Now, zinc. Zinc, now this is a discovery that zinc, it should be added to for children with diarrhea. And now, what is happening if you are administering zinc along with low osmolarity ORS? It reduces the duration and severity of acute diarrhea episodes in children below 5 years of age. So zinc is very important. Now, the latest dictum is that all children with acute diarrhea should be given zinc supplementation along with ORS and continue for 10 to 14 days. So if you go to pediatric ward, you can see for diarrhea, they will be prescribing zinc also. Now, there is an ORS that also consists of zinc. There are new ORS. Okay. So what is this zinc doing? So it actually inhibits the cyclic AMP dependent chloride transport across the mucosa. So this cyclic AMP dependent chloride transport actually causes this secretion of fluid. So this is actually inhibited by the zinc. That is the discovery. So like that, we will be reducing the secretion. So like that, diarrhea can be reduced. And also it strengthens the immune response and regeneration of intestinal epithelium. So understood? Zinc, it should be given along with other ORS, especially for pediatric diarrhea. Now, the second point, so we have corrected dehydration. Now, maintenance of nutrition. So the olden days, people used to say, if there is diarrhea, you should not eat anything. You should starve. So that is not the latest, that is not correct. It is not correct. So what happens if you are starving? Fasting decreases the brush-borne disaccharidase enzymes and reduces the absorption of salt, water, and nutrients. So if we are starving, the absorption of salt, water, and nutrients, again, it is reduced. So the patient will go for again malnutrition. So we have to give some feed during diarrhea. We should not fast or we should not starve. So like children, we can give, they can be breastfed or half-strung buffalo milk, and or we can give boiled potato, cooked rice, or rice kanji, then fruit juices, then chicken soup, yes, we can try. Then banana, sago. Sago, this, you may have seen this. In Malayalam, it is called a chavari. So that is also can be given. The chavari porridge we can make and give. So this is for the maintenance of nutrition. Now coming to drug therapy. Drug therapy, it is not advisable or justified to give drug therapy in all cases of diarrhea because only a fraction of cases there is the pathogenesis is by bacteria. And if you are giving antimicrobials, it may prolong the carrier state also. So now we will see certain types of diarrhea. This diarrhea can be non-invasive as well as invasive diarrhea. Non-invasive means there will be watery diarrhea, but there is no mucus or blood, and no fever. No fever, no mucus, no blood, but only watery diarrhea, and there will be frequent vomiting also. So this is non-invasive. So if this happens, we can be sure that it is due to the source of diarrhea will be small intestine. So there will be watery diarrhea, no mucus, no blood, no fever. So this is, it can be due to cholera or enterotoxinic E. coli, salmonella, Staph aureus, Bacillus cereus, etc. So such cases, non-invasive, that is if there is no mucus, no blood, no fever, what is the treatment? Only ORS. And if there is severe dehydration, we can go for IV, parenteral, and we no need of any antimicrobials. Okay. Now, invasive diarrhea. Invasive means a slightly loose, only small volume stool, but there will be mucus, blood, and fever. Fever will be there. Mucus, blood, and fever, and the volume is also less. And there will be abdominal cramps, urgency, dehydration, etc. But not much vomiting. Vomiting may be absent or sometimes very light vomiting. So that is, it is because of some enteroinvasive organisms. There is another traveler's diarrhea. Usually, when you travel to some places, immediately after your travel is over, you may get some diarrhea. Or people from abroad, when they are coming to, maybe we are going to other country or they are coming to our country, they may develop diarrhea. That is because of enterotoxinic E. coli or Campylobacter. So such cases, the antibiotics like ciprofloxacin, quinolones can be given, ciprofloxacin, norfloxacin, etc. Then another drug, it is called rifaximin. Rifaximin, it is or it is related to rifampin. That is our antituberculous drug. It is related to. So it is called rifaximin. Then invasive diarrhea, like the agents may be Shigella, Yersinia enterocolitica. In such cases, we can give ciprofloxacin, again, quinolones. Always, nowadays, quinolones will be the first choice drug if you are going for invasive diarrhea treatment. Ciprofloxacin, ofloxacin, norfloxacin, and also we can give cotrimoxazole or doxycycline. Now, so again I am telling antimicrobials, they are of no value in case of non-infectious infected disease causes like irritable bowel syndrome, then celiac disease, tropical screw, all these things you have studied in pathology. So you know what is it. So such cases also we don't need any antimicrobials. Then another pathogen for the acute diarrhea, especially in children, is rotavirus. So viral means there are no antiviral drug for treatment of this thing. So we have to just correct the dehydration. Then, where are these antimicrobials useful? It is useful in severe diseases like salmonella food poisoning. Again, this quinolones, ciprofloxacin or azithromycin, it is a macrolide or ceftriaxone. Then cholera. Cholera, you know, there is severe vomiting, diarrhea, and here also it is by Vibrio cholera. The number one drug will be tetracycline, especially doxycycline. Doxycycline, if you give one shot, that is, it will be curable for cholera. Then Campylobacter jejuni, it is norfloxacin. Clostridium difficile. Clostridium difficile, we have already discussed this. So this actually causes pseudomembranous enterocolitis. There will be bloody diarrhea. It is actually because of the Clostridium difficile. So such cases we can go for metronidazole or vancomycin. Then amoebiasis, giardiasis, this treatment we will be taking separately, but the drugs will be metronidazole, diloxanide furoate. These are the effective drugs. Now, probiotics. What are these probiotics? You would have heard of this probiotics. This is very effective. They are actually cultures or lyophilized powders, and that will restore and maintain the gut flora. Because the gut flora, it will be because of the diarrhea. There will be alteration for the gut flora. So to restore the gut flora, we use certain lyophilized powders or cultures that is called probiotics. So there will be recolonization because of this. They are actually non-pathogenic and they are lactic acid forming bacteria and yeast. So they will restore the gut flora. So the examples lactobacillus, then Streptococcus faecalis, Enterococcus, Saccharomyces boulardii. So these are especially lactobacillus. So that will lactic acid forming bacteria. So they are actually probiotics. So this probiotics reduce the antibiotic associated diarrhea. And this natural curd. So this is curd and the yogurt is an abundant source of lactic acid producing organisms which can serve as probiotics. So whenever we develop diarrhea or loose motion, so if you can take a lot of curd, this is very effective, very good when you are having diarrhea or yogurt. So what is the difference between this curd and yogurt? Any idea? Ashwini, Sunil, are you there?
Yes, ma'am.
Yes. Ashwini, can you tell me what is the difference between curd and yogurt? Curd, curd, natural curd.
Yes, ma'am.
Yes. How curd is prepared? You know how to make curd?
No, ma'am.
No,
From milk. From milk. From milk.
How will you make from milk?
Lemon juice.
Yes, yes. So by adding some lemon juice or adding another little bit of curd, that is also you can make. But what is yogurt? You know what is yogurt?
Yes, ma'am.
How it is prepared? Any idea? Or okay, I can ask someone else. Afnan, are you there? Why always when I call Afnan, you are not there? Shamima Rishana.
Yes, ma'am.
Yes. Do you know how you prepare yogurt? Or what is the difference between curd and yogurt? No or not? No.
No.
No. Okay. Anyone in the class? What is yogurt? Asif, are you there?
Yes, ma'am.
Yes. You know what is the yogurt?
Yeah, but I don't know how it is made.
So, what is the difference between? Have you tasted yogurt? Yogurt?
Yes.
Yes. So, curd means, as she was telling, Ashwini was telling, it is by adding this lemon juice, or we can directly a little amount of curd. If we put that will be to milk, it will be converted to curd. But yogurt, just by the bacterial fermentation, we have some bacteria only. So that is not prepared in our house. So that is called yogurt. So what I was telling, all these are probiotics. So in our house, curd is there. So if you have diarrhea, you or your family members or friends, if they have diarrhea, ask them to take either yogurt or curd. Okay. Now, some antidiarrheal drugs other than antibiotic, we will see some non-specific antidiarrheal drugs. So this can be grouped into absorbents and adsorbents, anti-secretory drugs and anti-motility drugs. Absorbents means it will be absorbing, like colloidal, then ispagula, methyl cellulose, carboxymethyl cellulose, and they absorb water and cell and all the toxins. Then adsorbents, they will be like activated charcoal. So they will be absorbing the toxins. Then anti-secretory drugs. So in the intestine, there will be two type of receptors. There is opioid receptors, delta receptors as well as mu receptors. So opioid, when you study in the class on opioid, you will be studying all these receptors. So delta opioid receptors are there and mu opioid receptors are there in the intestine. Many places it is there, but I am talking only about the intestine. And this delta opioid receptors actually drugs acting here, it actually it prevents the secretion, whereas mu receptors it prevents motility. So already you had studied for constipation, or I think I don't know whether it was discussed, but so delta opioid it actually intestinal secretion, whereas motility is regulated through mu receptors. Okay, that is the basis. Okay, now I'll be talking about one drug called Resica-Dotrel. Resica-Dotrel. So it is a prodrug which is converted to thiophan. And it is an N-caffeinase inhibitor. So listen, it is an N-caffeinase inhibitor. This N-caffeinase, this is an enzyme which causes the degradation of N-caffeine. N-caffeine, okay? N-caffeines are mu opioid receptor agonist. So in effect, what is happening? So N-caffeine should be there for reducing the intestinal hypersecretion. So N-caffeinase inhibitor. So it will prevent the degradation of N-caffeine. So that is the drug. Resica-Dotrel. It is an N-caffeinase inhibitor. So it is acting through mu opioid receptor. Understood? Not mu, it is delta opioid receptor. Understood? Yes or no?
Yes.
Yes. So Resica-Dotrel, it decreases the intestinal hypersecretion, but it won't affect the motility. There are drugs. I'll come to that. So Resica-Dotrel, it acts through delta opioid receptor, and it is good in we can use in children also, and mainly for acute secretory diarrhea because it prevents the intestinal hypersecretion. And minimal side effects like nausea, vomiting, drowsiness, flatulence, etc. So this is the latest drug, Resica-Dotrel. Then other drugs like just for informations, bismuth subsalicylate, and it will reduce the chloride secretion. Then anticholinergics, this atropine and atropine substitutes, they reduce the bowel motility and secretion. Octreotide, another drug, this is a somatostatin analog. Then opioids, etc. Now we will be seeing the so Resica-Dotrel acts on delta opioid. Now we will see some drugs that act on the mu receptors. So anti-motility drugs, it will reduce the propulsive moments. So by reducing the propulsive moments, it will enhance the absorption and there will be symptomatic relief in diarrhea. So these are all symptomatic relief only. So again, I was again repeating, delta receptor promote absorption and inhibit secretion. Mu receptors enhance absorption and by decreasing the propulsive moments. So one drug is codeine, another drug. In the have you seen this drug, Lomotil? Yes or no?
Yes.
Yes, ma'am.
Yes. Usually people go and take this drug, this Lomotil. So this is a combination of diphenoxylate and atropine. Diphenoxylate means it is an opioid. It is an opioid, diphenoxylate. Atropine, you know, it is an anticholinergic. This atropine, why it is added to this diphenoxylate? Because this is an opioid drug. So this may cause some addiction. So to prevent the addiction liability, this atropine is added. Atropine is an anticholinergic drug. So when you are taking atropine, it may cause some like anticholinergic side effects like dryness of mouth, etc. So the patients, they won't be addicted to taking this drug. Otherwise, if just diphenoxylate means they will be keep on taking because it may induce addiction or it may produce addiction. So that is why atropine is added. But the problem is it can cause respiratory depression and paralytic ileus and toxic megacolon in children. So if you people, if for diarrhea, if you are going to take Lomotil, have to be very careful. Only if it is very much needed, you suppose when you are traveling, so you have to for some emergency measures only you go for low model. Otherwise, please don't take it. It may cause some paralytic illness sometimes. Not all cases. See, many people would have taken, but only some 5% or 10% will be developing this paralytic illness or toxic megacolon. So, but there are chances. So, very careful. Then loperamide. Loperamide is again it is a mu that is decreasing the motility, mu opioid agonistic, an additional weak anticholinergic property. So no need of any anticholinergic added. So that is the loperamide. And CNS effects it is very rare. So that is loperamide. Loperamide again it can cause abdominal cramps, rashes, and toxic megacolon. So both loperamide and lomotil, they are causing all these side effects. So we have to be little careful. Then, but how when these anti-motility drugs should be taken? They are actually contraindicated in acute diarrhea because see when the diarrhea is progressing, if you are just stopping the diarrhea, if it is some bacterial diarrhea and we are just giving only the anti-motility drug, what will happen? All the pathogens it will stay there and it will be coming into the systemic. There will be invasion, so it will again increase the problem. So that is why anti-motility drugs are contraindicated in acute diarrhea. And but it can be used to induce short-term constipation, especially after anal surgery. So if there is some surgery for the anus, so we have to control it, isn't it? And to reduce the volume, fluidity, and backbleeding frequency in celeostomy. So people suppose there is a CA rectum. So this part it will be removed because of the CA, and they will be attached. They will be given only the colostomy. There will be colostomy, and the bag will be attached to this colostomy, and only through this the motion will be feces will be coming. So such cases, if it is it reduce the volume, fluidity, etc., we can give anti-motility drugs like this loperamide, lomotil, etc. Otherwise, for acute diarrhea, you should not go for that. Number one treatment will be our ORS. Then there is some one drug, it was recently, it is a chloride channel inhibitor. It is obtained from an American plant. It is Croton lechleri. It is from this plant, from the sap of this plant, one drug was isolated. Then our, what are the homemade, this thing, this nutmeg. You know what is nutmeg? Nutmeg?
Yes, ma'am.
Mohammed Najib, what is nutmeg? Hello. Hello. Mohammed Najib. People have just come and they are not answering.
Nutmeg.
Ah, nutmeg. Yes. What is nutmeg? What is the Malayalam name for nutmeg?
Jadika.
Yes, very good. So the homemade preparation, the combination of nutmeg with ginger. Ginger, you know, jaggery, you know, ghee. So this mixture, it is very good for simple diarrhea. Then rice kani, it is for Kerala people, we don't have to describe about rice kanji. It is one of the best home remedy for this diarrhea. This is to give nutrition. And everything it is there. So if you are adding salt, again, it is equivalent to rice-based ORS. So that is it. So I think that was the last slide.